Good evening, everybody. My name's Steve Teitelbaum. I'm calling from Los Angeles. I want to welcome everybody and hope you and your family are all safe on this very scary evening that we're now having. But I think let's just focus our attention on something that we all have in common wherever we are, which is how to make things safe for our children for the coming years until this pandemic has passed. I want to thank all of the people who've joined this call. We have principals and headmasters, epidemiologists, we have best-selling writers on the call, and interested parents and school directors. And I think this is the kind of group who can forge forward to create the best thing for our children. Our presentations will be by two people. First, Dr. Lakdawalla from USC. And it was this paper of his on pool testing for schools that got me very interested. And he was so kind to take my random cold call. And from that, this developed. And also Dr. Romer, who is a Nobel laureate in economics. And I got, can somebody please, everybody please mute. I got turned on to him back early in March when he was the first person to write about the importance of widespread testing through the asymptomatic population in the country in order to get our economy back on track. And if you look at paulromer.net, you'll see these terrific articles that he's written going way back. And he too, a Nobel laureate, answered a cold call of mine and is on this call. So the level of interest of collaborating and sharing knowledge is unprecedented and very exciting. I'm gonna give a very brief talk, then Dr. Lakdawalla, then Dr. Romer. Put your questions in the chat. I will try to organize them, ask a few condensed questions that cover most of the common interests, and then there will be time for people to ask their own questions on video. So my interest began because I'm a surgeon, and I was on a committee to look for safe testing of surgery patients and staff in the operating room.
I'm muted, yeah.
I'm also a patient, I'm also a parent, and when I went up to get my 5th cup of coffee, for about 2 minutes, my children decided to make a magnetile fort out of their computer, and it made me realize what really can go on no matter how excellent the Zoom curriculum is. And then I looked at what was actually happening in schools and got some scary visualizations of what's going on around the world.
My family. And
I realized that the way all of you in this call who are school directors have organized your classrooms that best fit the needs of those children at those ages are now being decimated. The notion of wearing 1 meter hats so that people know how, other children know how far to stay away is cute for a one-day lesson, but it's also concerning. Certainly wouldn't want to see my child having their lessons on the playground either. Classrooms were set up out of reason. They didn't arrive arbitrarily. And now we're looking at very draconian measures of uncertain benefit. Asking children about all of their symptoms every day, like you used to get asked when you would go on an airplane about whether you packed your bags yourself and anybody unknown to you took your bags. Temperature checks when we know that temperature and symptoms follow shedding by quite a few days. The 6-foot separation is very much safer than no separation, but 6 feet, 72 inches is not written in law or by God. This frequent sanitation and staggered schedules and 1 desk per student, 12, 16 students per classroom, masks all day, no recess, no sharing a ball, no playing with other children, shutting off the play structure are very sad things for all parents to imagine about how different their child's experience is going to be. If we do that alone and we do not test, there will be outbreaks. I'm not saying we shouldn't do those things, but even with those things without testing, there will be outbreaks. Schools will close. There will become sick parents and sick teachers and possibly deaths in our school communities. And God forbid, there could be some children who could get very ill as well. People are measuring 72 inches like this is going to be the perfect thing of health. And even today in JAMA, the leading medical journal in the country, you still see a lack of sophistication. When symptoms appear, prompt testing should be available. Well, by then it's too late because that child has been shedding for a few days. And the point of this presentation today, and that I want to drive home, is that we can't wait for the experts to guide us what to do. When the leading journals still put something like this in print, today, it shows that those of us on this call need to start to be doing something better tomorrow. Even today, Dr. Fauci, all of our hero, I'm sure, on this topic, when asked about a vaccine, said, if you are ready about manufacturing doses by January or just December, January, if you're lucky, if in fact the vaccine is effective, you can have a significant number of doses available by the end of the year, the beginning of 2021. So I think it's aspirational, but doable. The only thing that's the big unknown to me is it going to be effective? I think we could do it within the time frame that I've outlined, but there's no guarantee it's going to be effective. Another analyst said a 2 to 3 year timeline then is a more realistic estimate for when a vaccine will be widely available to the public. In the remote possibility that an approved, effective, safe, general use vaccine was available a year from now, blah, 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 we won't have herd immunity until 2023 or 2024. So for all of us parents and school administrators, we're in a marathon, we're not in a sprint. It would be magical thinking to believe that we only have to devise a plan for this fall. This is going to be for first and second graders. This is going to be people for 10th and 11th grade. This is going to be for a long time. And even if the testing we hear about today is not exactly implementable tomorrow, we need to be examining it with great interest right now so that we can roll it out when it is available. Even the expert, this one, who's everybody's favorite, he said for a while that masks were not important. Did he really believe they weren't important? Politically, was he pushed not to say that? The problem is we can't have perfect faith in what people are telling us. Barbara Ferrer, the head of the LA County Department of Public Health, I don't know her, but I heard she's a wonderful lady. But she has to oversee 10 million people, 108 cities, and 435 zip codes. I do not envy her position, but we can't expect her with all those varied responsibilities to know what's best at your school and for your child. We can't wait for her. We don't have someone like the fellow on the left, regardless of your political beliefs. We don't have someone like that that's going to be our leader to get us through this. This is my son and my mom, and grandmas deserve better hugs, and grandchildren better kisses. And students deserve better classrooms than this. And as parents and administrators, like this Henry Moore sculpture, we need to be strong like bronze around our children. We need to recognize that we're the adults in the room and that we can't wait for public health or for somebody at the federal government or governor level or city level to find out what's best. We need to look into it, and I think today is a great first start with two of the world's experts on testing, and I'd like to turn it over now to Dr. Lakdawalla. Thank you.
Thanks a lot, Dr. Teitelbaum. Let me share my screen. Can everybody see it okay? Are we good? All right, I'll take that as a yes. So what I want to do is talk to you about work that my colleagues and I have been doing at USC at the Schaeffer Center for Health Policy and Economics, and the applications for how we can safely reopen schools. I'm going to talk a lot about all the challenges and the effort we're going to have to put into overcoming those challenges. But before I do that, I think it's important to talk about why this is relevant and necessary. Why do we need to reopen schools? Maybe it's not so useful for this audience, but I imagine some of you are going to face these questions sooner or later. Why not remote learning? I think there are a number of reasons, at least two of them are, first of all, we know already based on evidence in the literature that lockdowns are very difficult for children. And as the parent of 2 school-age children myself, I probably didn't need an academic study to tell me this, but there are academic studies now that show that about 1 in 4 of school children under stay-at-home orders in China, the US, Great Britain, and other countries are exhibiting symptoms consistent with anxiety and depression related to stay-at-home orders. So one of the cruel ironies of COVID is that the groups that are less vulnerable to its physical health risks actually turn out to be more vulnerable to its mental health risks. That if you look at the data on anxiety and depression associated with quarantine, for instance, it's much more significant among children and young adults than it is among the elderly. So one way or the other, this disease poses a wide range of health challenges. The other issue here is that remote learning, I mean, in addition, as an educator, I myself have had to teach students remotely, and every educator is doing the best we can to make that work. But the reality is that remote learning risks expanding inequality and outcomes, because the more we shift the location of education to the home, naturally families with more socioeconomic advantage will tend to benefit more than families with less. That's an unfortunate fact. And reopening schools can help us mitigate that inequality. So for both those reasons, and besides many others, it's important for us to figure out how to make this work. And I would echo Steve's point that there's not going to be a magic bullet very soon. Yes, it's theoretically possible we'll have a vaccine next spring, but it would be a scientific achievement in terms of medical innovation that's probably on par with the moon landing. A lot has to go right, and it's more realistic to expect this is going to be a multi-year effort. So now let me turn to the issue at hand. And I want to begin by talking about the need for universal screening of students in schools. So consistent with Dr. Teitelbaum's points on this, there's now mounting evidence that COVID-19 spreads pretty efficiently among pre-symptomatic people. So there are people who don't appear to be sick, don't have any outward symptoms of illness, but they're spreading the disease. It's a little bit difficult to estimate exactly how significant this is, so we should take all these numbers with a grain of salt. But evidence suggests two things. One is that we have case studies aplenty that pre-symptomatic people have spread the illness. There was a striking case study recently about a Chinese family that had been on vacation in Wuhan, and during a pre-symptomatic phase, they infected half of a restaurant where they were eating, and everybody who was aligned with the ventilation of an air conditioning unit got sick as a result of that spread. Modeling studies, which are a little bit tricky to interpret, but nonetheless, they suggest that a significant number of infections are occurring during pre-symptomatic phases. The reason this is not that inconceivable is that, on the one hand, it's probably true that there's less viral load in pre-symptomatic phases, but on the other hand, pre-symptomatic people, by definition, are more mobile and therefore more able to spread the disease efficiently. So that could result in quite a bit of pre-symptomatic spread and be consistent with these studies. The other issue, which is relevant to reopening schools, is that we know, and this is related to the students on the playing field, that the overwhelming majority of infections occur indoors. There was a study by researchers in Hong Kong that looked at about 300 different outbreaks in China, and all but one of them occurred inside. In Japanese data, researchers are finding that transmission is about 19 to 20 times more likely indoors than outdoors. So the lesson here is that we need to have some strategy for screening asymptomatic, apparently well children, teachers, and administrators as part of our plans. Now, this is a tough situation, and the news may seem bad, but there is some good news here, and that is that we have a lot of different tools in our toolbox for containing COVID-19. And you as a school administrator should not feel that your policy has to check a bunch of predefined boxes. There's flexibility here in what you can do. And it's important to choose the strategies that work for your individual school population. So I want to give you just a way of thinking about this problem and what kinds of alternative approaches you can bring to bear. So a lot of people have been receiving a crash course in epidemiology over the past 3 months by reading the newspaper. And one of the things you might have learned is something called the reproduction rate in epidemiology. And the idea is the reproduction rate of an illness is the number of new cases that are produced by each sick person. COVID's reproduction rate, somewhat debated, but it's about 3 or 4. So that means if we do nothing and don't protect ourselves at all, each person sick with COVID will generate about 3 or 4 new cases. And that's why they're spread if we do nothing. That one case turns into 3 or 4, that turns into 9 or 16, and it grows. But the good news is that all of the precautions and strategies that are being contemplated are designed to lower this reproduction rate. And your goal as a school is not to eliminate every single infected person and make sure they never cross the threshold of your buildings, because that's impossible. This disease starts silently. And unless you're testing people continually, literally continually, you can't hope to achieve that. But your goal is to contain outbreaks and prevent them from accelerating. And that's an achievable goal. And the idea is you got to take that reproduction rate from 3 to 4 down to something below 1. Okay? And if we make that happen, if it becomes, let's say, 0.5 instead of 3, then each infected case generates only half of another, and so on, and it decays down to nothing. So there are 4 ways of doing this and 4 categories of strategies. One thing we want to do is, for every infected person, we want to limit their contagiousness. And this is the point of things like masks, seating arrangements, teaching outside or doing things outdoors more than indoors, sanitation. One point I want to emphasize, because it's become known more recently, is the spread through bathrooms. So we're learning more and more about the fecal transmission of this illness, and it's not a particularly pleasant subject, but flushing a toilet can spread the disease pretty efficiently. So congestion in bathrooms is something to be avoided, which means spreading out visits during the day so that there's not a huge line at recess and lunch, etc. So the first step here, or one strategy, is to reduce the probability that someone who's sick infects a person they run into or interact with during the day. The second thing is we want to limit the number of contacts that each infected person has. So there are a number of strategies for this. One is called cohorting. So you want to identify groups of students that you can reasonably separate and avoid mixing. In some schools, this might not be feasible. In other schools, it might be feasible. This is also the reason why some have proposed in workplaces and schools cycling groups of students or workers in and out, that half the students show up one week, then the next week that group learns remotely and another group returns to the classroom. So this also reduces the number of contacts that an infected person would have. And reducing congestion generally inside a building can do the same thing. The third, and this is the role of testing, is you want to limit the number of days that an infected person is still inside the school. And again, it is not realistic to believe that we're going to reduce this to 0 in every case. The goal is to figure out what can we do to limit the number of days in which an infected person is spreading the illness. And this is the rationale for testing. The final issue is we also need to limit the susceptibility of uninfected students to being infected. And masks are important here, hygiene and hand washing. There's another issue which is a little bit different, and that's what I call risk stratification, that some students deserve more protection than others. And we all know that students who have respiratory comorbidities are at greater risk and they may demand more protection. But another issue here is if a student lives with grandma and grandma has COPD, or a student lives with grandpa and grandpa has an acute coronary syndrome that leads to increased stroke risk, that's a high-risk student, even if that particular student doesn't have any underlying health conditions. So shared decision-making between families and schools and identifying those high-risk students and determining whether extra precautions need to be taken is warranted here. And I want to reemphasize this point, that you don't have to do every single thing. And some schools will find it difficult to do most of these things. And there are ways of handling that I'll get to. But we have to figure out what can feasibly be done and what students are going to comply with. Because if you implement a strategy, let's say it's masks, and the kids hate the masks, they're constantly taking them off, they're frustrated by them, it benefits nobody. It doesn't actually reduce the spread of the illness very efficiently, and it defeats the purpose of reopening schools, which is to provide a more pleasant and motivating learning environment for kids. So the goal here is to find social isolation controls that kids actually are, that your kids are able to comply with, and finding that right mix is a function of the individual school, not a rote recipe book that anybody can give you from outside. Now, turning to testing, which is an important focus of this discussion. Actually, would you mind muting? I'm getting a little bit of feedback. Thank you. So universal testing is the backbone, I think, of a school strategy, because a lot of what you'll be doing is adapting to changing circumstances, loosening controls when infection rates fall, tightening them when infection rates rise. But it's tough to do that when you don't know what the heck the infection rate is. And that's the importance of monitoring and surveillance. And again, symptoms monitoring it's fine. There's nothing particularly wrong with checking temperature. It's just not very reliable because kids will be sick, or teachers for that matter, will be sick for days before their temperature spikes. And in fact, some students might never see big temperature spikes. So the probability of asymptomatic spread makes testing crucial. There's not a single rule for how frequently you should test or how you should test. There has to be some adaptability to change, and I'll talk about protocols for thinking this through. But quite frankly, I don't have there's no ready rule book for how to do this. This is new territory for everybody, even those of us in healthcare research. But what I'll try to do is be as practical as possible in giving you strategies for coping with this at your schools. So how can we screen asymptomatic people? And functionally speaking, there are three ideas in the literature on public health and in the discussion around opening schools and workplaces. What I call the traditional approach is let's test the symptomatic. And I think Dr. Teitelbaum put up a couple of examples of that where that's the thinking. Monitor for symptoms and test people who are exhibiting symptoms. The problem is that this doesn't get any of the asymptomatics. I mean, maybe it gets some if you do contact tracing along with that and test people who are exposed, but it's not a very efficient way of tracking down pre-symptomatic cases. Another strategy is you test some fraction of asymptomatic students on a rolling basis. Let's say it's 20%. Well, that's better than nothing, but obviously you can't do better than finding 20% of your asymptomatic students. And maybe since tests are not perfect, maybe that's as little as 15%. And if it's really true that 50, 60, 70% of infections are caused by asymptomatic cases, this just isn't enough. I mean, you're not really making a significant enough dent in the spread of the illness. So the last idea, which is not a new idea in diagnostic testing. It dates back to World War II when it was proposed by an economist named Robert Dorfman for screening draftees into the Army for syphilis. And I'll talk about this in more detail. But the idea behind what I'll call pooled screening is that instead of pursuing random individual testing or no testing of the asymptomatic whatsoever, you use a process called pooled testing to screen people who are likely to be sick. And let me show you exactly what I mean by that. So think about, just for an example, think about 125 students. And suppose we split them up into 25 pools of 5 students each. So that's the schematic here. Each one of these boxes contains 5 students, and there are 25 total boxes. The idea is within each box, there are 5 students. And what you do, the reason we call it pooled screening or pooled testing, is we literally pool their specimens together and figure out, first of all, if the group as a whole is positive or negative. So here's how this works in practice. And here's how it helps us to economize on the cost of testing. So the first thing we do is we test these 25 groups. And it is kind of what it sounds like. I mean, you're combining, this is all done at a lab, so you don't have to literally pool samples, but you're combining samples at the lab and determining which of these groups has evidence of virus inside the group. So you test these 25 pools. And let's say in this example that 5 pools come back with some positive viral particles and the other 20 groups come back with no viral particles. Well, what have we learned? We've learned that most likely 20 out of the 25 groups don't have a sick kid in them, but 5 out of the 25 do have a sick kid in them. So what we do next is we take those 5 groups that tested positive and we focus on testing the 25 individuals in those groups only. And then let's say we find out, oh, within each of those groups, there was 1 sick kid. So ultimately, we identify the 5 children out of 125 whom we tested, but instead of having to field 125 separate tests, we got to this result by just fielding 50 tests. Okay, so it's less than half of what we had to do. And traditionally, in the United States at least, we don't engage in pool testing because we don't face situations where we're so resource constrained and can't field individual tests. But COVID is a brand new beast, and having to test everybody repeatedly and continually far exceeds at least our current capacity as a nation to test. So pool testing can be one strategy for us to use to make testing more cheaper and viable. Now, this raises a number of questions about how we implement this. And one question is, how big should the pools be? So in my example, I said, well, let's pool 5 students together. But the reality is that the answer to this question depends on 2 kinds of competing issues. If we make the pools really large, then the possibility is that a lot of them are going to come back positive. Because the larger we make the pools, the greater the chance is that someone who's infected is going to slip into that pool. And if every pool's testing positive, it kind of defeats the purpose of pool testing to begin with. Because you got to test all the students individually inside positive pools. And if the vast majority of your pools are proving to be positive, you're going to end up testing the vast majority of your students individually anyway. So we don't want that to happen. On the other hand, the needle you have to thread here is if your pools are too small, then it's not all that helpful. I mean, if you pool just 2 students together, then you're still running a ton of tests on 125 students. I mean, you're running at least 60 tests, probably more when students are sick. So we want to thread the needle and find what is the optimal pool size that gives us the lowest number of tests per student. And one thing that we'll find is that you can afford to make your pool sizes bigger and have much larger groups when you're dealing with lower infection rates. So I'm going to show you a couple of rules of thumb for how to do this and give you some practical advice on what this means for you. So just to kind of give you a little bit of context, what are we talking about in terms of pools for different kinds of infection rates? If you're in a school and you think you have about 1 out of every 100 students infected, then the best you can do is have pools that have 11 students each. On the other hand, if you're in a school that has 6, 8, 10% of students infected, which is an extremely high rate of active infection, by the way, those are New York City proportions, then your pool sizes should be smaller, 4 or 5 students apiece. And it turns out if you do all this, then you can save a ton of money. That you can say if your infection rates are low, you could save over 90% over individual testing. Even if your infection rates are higher, you can still save about 50%. Now you may be looking at this and wondering, how the heck am I going to solve this complicated pool sizing problem? And that's right, you shouldn't have to do that. So the really good news is that very simple rule of thumb pooling strategies work pretty well. Suppose all we did was we said, you know what, we're going to pool 4 students together. We're going to, let's say you have classrooms of 20 kids, and we'll split each classroom up into 5 pools of 4. That works pretty well. You can see that it matches this gold line, which is the best possible outcome you can achieve, pretty well for lots and lots of different infection levels. Sure, if your school has very few cases, you could maybe do a little better by increasing the size of the pools, but you're still doing well. You're saving 75 or 80% over testing in every student individually. So a simple rule of thumb like let's have 4 student pools is easy to implement and it works pretty well. Now you should be able to increase the sizes of your pools if you find out that you're facing a much lower rate of infection in your school. But you gotta be a little careful. Like let's say you said, I think I have very few cases, so I'm gonna pool 11 kids together. That's okay if you have infection rates that are below 3, 4, 5%. But if you end up with lots and lots of infections, the problem with a big pool is that you're going to get a ton of them that test positive because some sick kid is going to end up in each one of your pools with higher probability. So a good rule of thumb here is look for moderately sized pools of 4 to 6 kids each. Now, there are some concerns about pool testing that have been expressed, but on balance, it's probably a better idea than traditional individual testing. One of the issues is we're concerned about false negatives whenever we test students. We don't want to test a student and say that student's healthy and release them back into the school when they're actually sick. And this has been a problem for all our COVID testing, frankly. It's probably due in part to poor technique when people collect nasal swab specimens. Some studies have suggested that there are rates of false negative that are as high as 30%. That means that if you have 100 sick kids, you're only going to detect 70 of them when you run nasal swab tests. Now, those numbers are improving over time as people learn how to use these tests better. But the important point from the perspective of pooling is it is possible that when you pool samples, you make these error problems a little bit worse. And the issue is if you put a bunch of samples together, you're inherently diluting the amount of viral material that's produced by 1 or 2 sick kids in the pool. But it's not a huge effect. And moreover, considering that the alternative from a practical standpoint is just not testing anybody who's asymptomatic, it's certainly better than using it's certainly better to use a pretty good pooling test than no test at all. Now, you might also be wondering, okay, so how, even if I start doing this and I start testing my kids, how often should I do it? And again, there's no magic rule here that works for every case, but I'm going to give you a couple of principles to think about this problem. The first point is that if you're experiencing an increase in cases, then test more frequently. Like you might want to start with a simple strategy of testing kids however often you can afford it, whether that's once a month, every other week, once a week. And if you're finding a lot of cases are positive, then maybe you should be testing more frequently. Maybe if you're doing a weekly test and you get a lot of cases on a Monday, maybe you should test on Tuesday and see if there are other cases appearing. Some of this is just common sense, and even though we don't have evidence to deal with every single eventuality yet, it's okay to use your common sense, especially when there's no specific evidence in the literature. That's kind of a problem for us today. The other issue is if you're in a school that finds it hard to implement some of these social isolation controls. Maybe you find it hard to reduce the number of students attending school. Maybe it's tough to find classrooms big enough to maintain some physical distance. Whatever the case is, you ought to be testing more frequently if it's harder to limit spread by other means. And vice versa, if you can implement a lot of other strategies to limit the spread of infection, you can probably afford to test less frequently than your peers. And that might be a more cost-effective approach for some schools. And the third point is, if you're worried about reliability, you can afford to test less frequently if tests become more reliable. That as our tests get better, you'll be able to test your students less frequently. So as we adapt our strategies, suppose our baseline approach is, let's pool 4 to 6 kids together, and then let's implement whatever social isolation controls are feasible in your school. And that's going to vary from one school to the next. And then simply put, I mean, these are many, many times driven by resource constraints. Test as frequently as you can afford. Okay, just if you're not able to test weekly, it's okay to say, okay, I can afford to test monthly, so that's what I'm going to do. It's definitely better than not testing at all. So test as frequently as you can afford, but then have the flexibility to adapt. If you find yourself in a situation where you're getting more positive cases than you expected and infections are accelerating, test more frequently. Take it from once a month to every 3 weeks or every other week. If you're getting lots and lots of pools of students that test positive, make the pool smaller. Right? There's no magic formula that's going to work right out of the gate for every school, so don't be afraid to experiment in sensible ways. Another point here is that the way that you design your test frequency depends on how aggressive you want to be in removing students from infected students from your school. So this is some work that's was recently done by a colleague, Dr. Zeph Landau at Berkeley in the Department of Computer Science. Zeph has been doing some excellent work in the area of testing. And the issue here is there's something called lead time, which basically means the number of days between an infection and the date we detect it. So the longer is the lead time, the more days the student has been circulating with their infection in your school. So let's think about how frequently we need to test as a function of how much lead time we want to tolerate. So let's suppose we want to make sure that students are caught within 3 days of being infected. Maybe you're not comfortable with that, and maybe you want to tighten that up, and that's fine too. But let's start with this as a point of reference. So if that's what you want to achieve, then you really ought to be testing about once a week if your tests are really, really accurate. And the idea is that if you're testing, let's say, to use even numbers because they're a little more convenient, let's say you're testing every 6 days, then on average, the average student who's getting infected between those tests is getting infected on day 3, right in the middle. And that student is hanging around about 3 days in school. So if that's your goal, then test every 6 days, about twice as long as the lead time you want. If you want infected students to be caught earlier, then you need to decrease the frequency of your testing. For instance, if you want to catch students within a day on average, you're going to have to test every other day. If you want to catch students within 2 days, you'll have to test, twice a week or so, every 4 days. I don't need you to pay deep attention to the graph other than to note a few major features. That if you want to catch students more quickly, you need to test more frequently. The other aspect of this is that you can use more frequent testing as a substitute for tests that might not be perfect. For instance, if you need to do home collection, that's going to be less reliable than having a healthcare provider collect the sample. And that's okay. It just means that you might want to test more frequently because if you miss a kid the first time, you might get him the second time. And that's the logic behind increasing the frequency of your testing. Now, the last thing I'll talk about, and then I'll hand it off to Dr. Romer, is how do we think about selecting the pools? So most of the evidence on this just assumes you bring together random people in pools and you test them, and this is just a way to reduce costs. But in the school context, there are ways of doing this a little more intelligently. One strategy is you could pool by classroom. And the logic here is that even the pooled test is helpful because if you just know some student in this classroom is sick, it probably makes sense to quarantine that particular classroom, or at least take particular measures to contain infection in that classroom. The other issue, or the other advantage here, is that inside a classroom, if there's one student that's sick, it's reasonably likely there are other students who are sick. So you'll have multiple positive children in that pool, and that addresses the problem that the sample might be too diluted to see the virus. For the same reason, you might, if you can and you have access to this, some schools will and some schools won't be able to do this too. Pooling by household or family can help as well. This for the same reason. If someone in the family is sick, it's more likely that someone else is sick too. And if there's a sick case inside the family, you probably ought to do something about quarantining that family anyway. You can do both these things together, and it's something called multi-dimensional pooling. And the idea is here, we just want to identify cases that are occurring outside. That's the idea of family pooling. We want to limit the spread of cases within the pool. That's the value of classroom pooling. So we can take infected classrooms and quarantine them. And then we can do these two things together. And the nice thing about this is, suppose you test 3 classrooms and you find one of them is positive, and at the same time you're testing families and you find that there are 2 positive families. Well, if you take these 2 sets of tests together, you can probably identify exactly the kid who's sick. That the kid who has a positive classroom pool test and a positive household pool test is the sick kid, right? If you're in a positive classroom but your family tested negative, you're probably one of these negative kids. So you can exactly identify who's sick and even quarantine the specific student. Now let me close by talking about some of the next steps for getting these processes approved. And it helps to, I don't want to dive too deeply into the minutiae of FDA approvals, but it helps to understand that when the Food and Drug Administration approves a diagnostic test, it's approving an extremely specific process for testing. So it might be approving, we are going to test people who are symptomatic, and we're going to collect that sample in a doctor's office, and the sample is going to be shipped to a lab, and the lab is going to report back a test to the patient. Pooled screening is going to require a different set of approvals. It'll require labs to seek approval for testing asymptomatic individuals, including children. It'll require labs to say, we want there to be self-collection of samples at home, not professional healthcare provider collection. We want to be able to pool the samples in our test equipment, and we want to do it however you'd rather do it, using a saliva test or a swab test. The good news is that large commercial labs in the US are already pursuing these kinds of approvals for pooled asymptomatic testing. Hopefully we'll see the first authorizations come out over the next few months in time for the fall. There's already now a test that's authorized for saliva. Rutgers has done that quite recently, and hopefully more will come online. It's going to be difficult, in fact, maybe unworkable, to perform nasal swab tests weekly or biweekly on children because it's not a fun experience. But as saliva tests come online, this can be a way to solve that problem. So I'm really looking forward to the discussion with all of you, and I'm delighted and also looking forward to Dr. Romer's remarks. Thank you, and I'll hand it over to Paul right now.
Okay, I'm going to try and share my screen to just provide some context. Steve, are you seeing 2 graphs?
Yes, sir. It looks perfect.
Oh, okay, good. So I just wanted to start with some bad news and make sure we understand how little progress we've made in dealing with this disease. This is from the site that I find has the best record of tracking where we are and forecasting where we're going. If you look at deaths, what you see is that there was a peak in about mid-April, and the number of deaths per day has declined since then. But this is exclusively a phenomenon in the New York City area, New York, New Jersey, Connecticut. They had a very high peak, and they have come down off of that. The rest of the country has basically reached this level of the reproduction number equal to 1, where we're just infecting the same number of people every day, the same number of people are dying. And this is true of California, for example. There really hasn't been any kind of a decline. There is a small forecast, that we're continuing to get some improvements because of reduction in deaths in infections in the New York City area. There may be a little bit of benefit from the summer as well because of the seasonality. But basically, we can just project for the rest of this year, something like 1,000 deaths per day, and take that as a sign that most parts of the country have stopped the rate of increase, but are just letting it continue at the levels that we've got right now. So I think that's the forecast going forward. I also would strongly emphasize the point that the vaccine, in the very best case, starts to play a role in the middle of next year. And so we've got to deal with an ongoing pandemic. on which we've made very little progress getting it under control. And we got to have a plan for dealing with that for 12 months, 18 months, 24 months at least. So with that, I'm happy to just stop the share. I won't use any other slides. Beyond that, it's just me. So we've done very badly in managing this pandemic because we weren't prepared. And, you know, bygones are bygones. It's not worth worrying much about, you know, why we weren't prepared. But we need to learn the lesson that if we don't make preparations for the stuff that's coming, we're going to be in as bad a position for dealing with the coming problems as the position we've been in up till now. Somebody described this to me by saying that the best time to plant a tree is 20 years ago, but the second best time is to plant it today. You know, there are a lot of things we didn't do in the past, but we need to do things now that could make sure that we have a better future. And we've really made very little progress in doing those things. As part of committing to doing the things we need to do, I hope that one thing that everybody agrees is that we commit now to opening schools in the fall. You can have a rule where you look at evidence, you look at things to develop, you decide under certain contingencies, we would not open schools, we would not have students in classrooms in the fall. But we need to commit now that until we see that kind of sign, we're going to go ahead and plan to open schools, because that will force us to make decisions and to make some investments, make some plans that we might otherwise procrastinate on and say, well, let's just wait and see how things turn out. So we need to commit that we're going to open schools. We need to commit that to make it safe, there are a number of things that we have to do. A second point, which I wasn't sure how blunt I wanted to be about this, but Steve has encouraged me to go ahead and just do this. We cannot rely on the authorities right now to make plans for us or to give us good guidance. At local levels, at individual levels, to a large extent, we're on our own, and we need to make plans that make sense for us. I think there's several things that feed into this lack of reliable leadership right now, lack of authority that we can trust. But one element of it is that because we got caught short, we said things, or the authorities, the leaders said things that didn't make sense, that weren't true, and that have actually kept us from making the investments we need to make. I mean, think about personal protective equipment and masks. The CDC, Dr. Fauci, they said, you know, you don't need to wear masks. Masks aren't helpful. It's just not true. And we said that because they were worried about an insufficient supply of equipment for people working in hospitals. But that not only made the disease worse, we lost the chance to contain the disease by wearing masks, but we also lost the urgency to increase the supply of masks because the authorities were saying the masks don't help. So we said things that weren't true. That kept us from making investments, which has now meant that two months later, after we first started talking about this, we still don't have the basics, like enough masks for everyone to wear. And we're still talking about the public should only wear cloth masks because we're worried about the public asking for the better quality masks that would be most valuable in healthcare settings. So there's a really very troubling, I think, lack of kind of credibility and legitimacy in the messages we're getting from authorities. If you look at what the CDC says about opening schools, the CDC does not even mention the idea of testing students or staff. They acknowledge that there might be some people who get tested for some reason. They talk about what you might do if someone tests positive. They do not say anything about the possibility of intentionally testing students or staff. They do recognize it would be good to know who's infectious. They suggest doing things like temperature checks as a way to see who's infectious. But as the discussion so far has made clear, temperature checks or anything that relies on symptoms comes way too late in the process to catch the asymptomatic spreaders. So the CDC is recommending for schools something which we know it failed in nursing homes, but yet without even recognizing how really inadequate a measure this is, it's just sort of blandly saying do temperature checks in schools. So, you know, I think we cannot just rely on what the CDC is telling us about this. The other problem is that we've made very little progress towards better ways to do testing. And there are all kinds of ways to do testing better. In this case, the FDA is an enormous bottleneck on the better ways to do tests. The pooling strategy that Darius described is something that, for example, is being done in Nebraska, but it's being done in Nebraska in a way that violates the FDA approvals for the testing system. They did it anyway because they got protection from the governor. The governor just said, do it. But it wasn't legal to do the kind of pooled testing that, that Darius was describing. He also mentioned that there is a way now that's approved for doing saliva testing, but for an entire month after that was approved, the only legal way to do saliva testing was to spit in the tube in the physical presence of a doctor. And then the people who got this approved finally persuaded the FDA that you didn't have to be in the physical presence of a doctor to spit in the tube. You know, the FDA wasn't even allowing the doctor to supervise you over Skype for this. But it's still the case that this one lab in Rutgers is the only place in the country where it's legal to do tests based on saliva samples. And if anybody else is going to do it, they're going to have to go through all of the paperwork and all of the trouble that this one lab in Rutgers went through. And if you look at all of the things we've heard about the bottlenecks in testing, there aren't enough swabs, there's shortages of reagents. People in university laboratories solved every one of those bottlenecks by innovating around them, but those innovations have not been deployed because none of them are FDA approved. So we face a problem right now of no progress, a very problematic 12 months that we're facing, and leadership that's either not telling the truth, not grappling with the seriousness of the problem, or just getting in the way. And I think the CDC and the FDA, they're people who are basically trying to do their best, but they've just lost control of the big picture. They're like a bunch of drivers in gridlock when cars have stopped following the rule of don't block the box. And everybody's saying, well, you know, I can't really move. There's all these other cars in the way. There's something else which is causing it. But nobody's stepping back and looking from the higher perspective and saying, we can be doing much, much better than this. So I think action at the level of the states and the big school districts may be important for getting some real leadership for the whole country on these problems. Now, let me point to one area where we actually have seen some progress. The Congress allocated $25 billion for testing, said that 11 billion of that should go to the states. My understanding is that means that California will get about $1 billion for testing, and then it'll be up to the governor to decide how to use that money. I think it would be very important to make a strong case as soon as possible that that money should be allocated for testing in schools. I'll come back and say some more about that, but let's suppose we can get that established. The other thing that's happening is there's going to be another bill, most likely, probably in July. The House passed a version of this. The Senate will come back with something very different, but the House proposed $75 billion in additional spending on testing based on a target of $100 billion per year in testing that I and others have been pushing. And I think there's a reasonable chance that that $75 billion might actually make it through as part of a bigger infrastructure spending program in July. The more we can send a message to people in Congress that that would be important, the more likely that would happen. And I think the most effective way to use that would be to have the same system in play where the money goes to the states, governors can make decisions, and then you count on your governor to allocate money to schools as one of the top priorities. Now, that's the good news. The bad news is even at spending of $100 billion a year on testing, we're not going to get to the level of testing we need to really address this problem for the nation unless we can get the cost of tests down from about $100 a test to $10 a test. What the big companies like Quest and LabCorp get right now is $100 per test. We can get the cost of this down way below that, but they, of course, have no incentive to get below this. It's a very lucrative opportunity for them. So the real opportunity here is to have governors say, we're going to do screening tests that are not FDA approved. They're not clinical diagnostic tests. They don't qualify for reimbursement from insurance companies, but we have our money. We'll pay to do these tests. We'll pay the providers, who will be university laboratories. There are laboratories all throughout California that can scale up and do this kind of testing. They can do the pooling that you've heard about. They can do even more sophisticated versions of this with what they call barcoding. And they think that if given the technology that's known, they can scale this up to like 10 times or more, 100 times the throughput in laboratories that we're getting from these big companies. And if we give them the freedom to do that, we can get this down to something like a cost of $10 a test. So we need to have a regulatory regime where the governor says, I'm going to pay for tests. I'll pay so much per tests through the school systems. And if you're a laboratory, the only thing you have to do to qualify for this is show that the way you're testing meets specified criteria. You tell us what's your false negative rate and what's your false positive rate, and then everything else is up to you. And you don't have to go through this micromanaged step-by-step approval by the FDA. There's nobody's health is at risk here. There's no reason for the FDA to be so controlling in this area. Now, if you're a school and you're doing screening, don't even call it testing, screening based on a lab at Berkeley or UCLA, USC, if you're doing the screening, what do you do when somebody tests positive? You just tell that person, you need to go get a test from the one of the companies that can provide you with the FDA certified clinical diagnostic test, and it's going to show you that you're positive. When you test positive under that regulatory regime, somebody can actually tell you you're positive, and then you proceed from there. But the number of people who are going to test positive is going to be in the low single digits if you're doing these screening tests at $10 per person that are not FDA regulated, that aren't, clinical diagnostic approved tests. You do those at $10 a person. The few people you get who test positive, you go retest, pay the money, get it reimbursed through health insurance, and then away you go. So there is a path that could work here, but it's going to take some courage and some leadership at the state level. I think California and New York are the two best states to do this. And I think it also is going to require success in getting the Congress to put up money to make it possible to do tests at the scale that we need. So, that's as much as I'm going to say about, I think the urgency and the opportunity here to do more testing. For the time that I have left, let me try and just outline what I think might be a kind of a decision tree if you're a school administrator. So the ultimate decision, the decision that has to be made now is you are going to open and have people in classrooms in the fall. You can revisit that decision before people show up in September. You could revisit it even as the school year goes on. If there's, particularly bad information, you could shut the classrooms down. But we need to just commit now that we're gonna have schools open. Then there's a bunch of things to think through. One is, do you require masks? Do you maintain the 6-foot separation, the kind of the CDC type recommendations? I'll come back and comment on those in a minute. Do you collect data? This is something that Darius mentioned, and I think this is essential. You've got to have at least enough data to see what's going on, to see if things you're trying are working, and also just to see, are you being blindsided by other developments about this disease that we don't anticipate. So I think you have to commit to collect data, to have some sense of where are we, what's working. I think it may also be a very good idea to try several options, especially in a big school system, because this is going to be the best way to learn. Now, as you can imagine, and I think we agree, Darius and I think it would be a very good idea to test both students and staff, but this is going to be controversial, and I think we should talk through some of the opposition you might get and some of the ways to handle that. There's one other element that I think is worth mentioning right now. There are ways to actually deal with the infected aerosols in the air. To control tuberculosis, public health officials have developed ways to use ultraviolet light to actually kill bugs and viruses in aerosols, in droplets that are circulating in the air. You install these where the light doesn't shine in anybody's eyes, so it doesn't damage anybody's eyes, but just the convection currents that take the air up to the ultraviolet light can actually disinfect the air. So that if you do have people in the room who are infectious, you're less likely to have the spread of these aerosols to others and then infect them. This is not cheap to put in place systems like this, but I'm going to come back and say why I think there might be an opportunity to do it. The other strategy, of course, is to use more ventilation, just increase the rate of inflow and the rate of outflow of air into a room. There may be ways to just turn up fans to increase that, but the effect of the disinfection can be like adding 10 air changes per hour, the equivalent of 10 air changes, which is a lot of ventilation, if you just are killing the bugs that are actually floating around in the air. Now, let me say why I think this might be worth thinking about. The way I think about aerosols, and it's not just droplets, it's aerosols. Aerosols are like cigarette smoke. So you want to think about how close do I need to be, or how far away do I have to be so I don't smell somebody's cigarette? And how effective is a mask, a surgical mask, going to be to keep me from smelling the cigarette? You got to be a long way away, and the mask is not going to stop you from smelling the cigarette. And that's telling you that if there are these very fine aerosols with virus in them, you're going to be exposed to them. So I don't think this 6-meter rule, which is based on droplets rather than the aerosols that spread like cigarette smoke, there's growing evidence that a lot of this transmission is through the aerosols. So I don't think the 6-meter rule is going to help that much. The masks help some, but even they are not necessarily going to be perfect. So I think there's reason to think about, you're going to have some infected kids releasing aerosols in a room, and it would be good if there were a way to disinfect the air, or to get more ventilation through the room. The bathrooms are going to be a particularly important place to have a strategy for either much greater ventilation with fresh air, or disinfection of the aerosols that have spread in the room. Hand washing and all of that that's good, but it isn't going to help you to fight these aerosols. Now, why am I pushing this? The focus in this bill, which will be like $1 trillion the Congress will spend, and from an economist's point of view, if the Congress just spends money and tells people to go do something, it's good for the economy. It doesn't really matter what they do. It just kind of gets people employed. It primes the pump and so forth. One of the things we could make a pitch for is some significant investments in adaptations that would improve air quality in classrooms. Some of this can be done through central ventilation, but some of this could be like installing these systems that could actually have the ultraviolet lights that are disinfecting the air even in the rooms. Ordinarily, this might not be the most cost-effective way to deal with this problem. This will depend partly on how quickly we can scale up the tests and how accepting people are of testing. But it's just conceivable that we could get into this next bill, another $100 billion in improvements and investments in air quality in classrooms. and that might be, you know, a useful complement to what we try to achieve with the testing. Now, let me just do a quick time check. Steve, how soon would you like to turn it over to Q&A?
I know there are a lot of questions. Everybody wants to hear from you. So finish up what you want to say and we'll go to questions.
All right, let me take no more than 5 minutes and then finish. I think it's important as we start to plan to think through right now a bunch of questions. Like, what do you do when a student tests positive? Are you going to say the student stays home, or does the student go to a classroom someplace? That's the first question. The second thing is, do you mainstream that student, have that student wear a mask, or do you have that student go to some separate facility? Is that facility on site in each school? Do you have kind of separate entrances and so forth? Or do you have a separate facility where kids who test positive may go? This is going to depend on calculations like, what's the prevalence? How many of these kids are we going to identify who test positive? So there's some work to be done there. But part of the connection here that I'm thinking is, if you have places where you're going to have kids go who test positive, those might be particularly important places to make these investments in, for example, the disinfecting the air, because it may be very important for protecting staff and, possibly even protecting kids from each other, where somebody with a mild case could get an even worse case if they get too much viral load. I think it would also be important in terms of acceptance of this to think about whether testing, if you're going to have a testing program, is it mandatory? Or do you say that there are going to be some schools where the commitment is, if you go to this school, you have to get tested? Can some parents who object to this have the option of going to schools where they don't get tested? So you've got an opt-in feature. And it's a bad idea, but it may be important if you want to avoid some kind of anti-vax kind of protest about, the state forcing people to go to schools and then forcing them to get tested. I think I've really covered all the points that I wanted to make, but let me just come back to this problem that we don't, the thing that interested me when I first started interacting with Steve, when he tried to get me to, come on this call, is that here's a surgeon who clearly, I was reading between the lines, but he was not satisfied with what the CDC was saying. And frankly, I think, like me, doesn't think they're really, giving us the whole truth. So this is a very uncomfortable situation to find ourselves in. I don't think it's an easy one to fix, but I think the way forward is for us at local levels and as individuals to just seize responsibility and make some plans for moving forward, because this is an incredibly dangerous time, and we can't just wait for authorities to address the problems we're facing, because I think if we do that, we're going to fail.
Thank you, Paul. Thank you, Darius, for those great talks. We want to open it up to the floor. One question that comes through. You have on this call school principals, and you even have on David Baca, who's the point man for all of LAUSD, 700,000 students and like 80,000 faculty. If tomorrow they decide they want to look into this, is there yet a person for them to call, or do they have to create their own path forward?
There are some resources they could call on. The Rockefeller Foundation is one place I've been working with that's trying to provide a kind of a clearinghouse function. Darius, but there are also local resources, like, people like Darius. So I think it's not as though there's one authority for the whole country, but I do think there are people that they can get help from. Darius, do you want to respond on that?
Yeah, I think that's a good summary. I would say that there's no out-of-the-box solution right now, but there are people who can help, and as Paul mentioned, there are clearinghouses out there and people who are trying to make progress on this. And the other point is, this is a dynamic and evolving situation, and where we are in July is going to be, I think, better off than where we are today. So it's important to monitor how these approvals take place and what happens with diagnostic testing over the next few weeks and months.
Steve, one other thing, if I could just mention, is that in a time where there's like so much fluidity and so much uncertainty, a few people can actually make a difference. I have no idea what the governor of California is thinking about doing with this testing money, but if he just got a call or repeated calls from LA Unified saying, take that billion and devote it all to getting testing, ramped up for schools, that might actually influence how that money gets spent.
There are three people on this call who are really important, and I want them to sort of meet one another and also to meet you, Drs. Lakdawalla and Romer. One is Dr. Ann Willey from Yale. She is the first person to publish about the sensitivity of saliva and able to do it without expensive. So I want her to talk a little bit about that, and that she's actually working on pooling saliva. We didn't talk about how tough it is to put swabs up kids' noses, but this is important. And then we also have Dr. Tomer Hertz from Beersheba, Israel, who developed a very sophisticated algorithm for pooling that involves control of robotic pipetting arms, and also Dr. Dror Barron at University of North Carolina State. So I'm wondering if Dror and Tomer can each say a word after Ann for a moment. Ann, can you unmute and tell us about what you're doing with saliva?
Yeah, sure. Thanks, Steve. So as Steve mentioned, I'm Ann Wiley. I'm an associate research scientist at the Yale School of Public Health. And we have been working on, well, actually been helping to co-lead the virology section and the testing of our biorepository for COVID. It started off as COVID-19 in patients, but we do also have an asymptomatic cohort, which we've been using to screen healthcare workers who are asymptomatic, and taking both saliva samples and nasopharyngeal swabs and just comparing them for detection of SARS-CoV-2. So it's been really great to hear what you're all talking about, and especially some of the points have been brought up about pooling. And I hadn't actually thought about it yet because there's just so much going on, but I really like the idea and the concept of the reactive pooling. So depending on what's going on, how big your pools are and how often you're testing, I think is a really good and important thing to consider. And of course, I think saliva is going to be the thing that everyone needs to be considering as well, just because, if you're asking kids to take these samples every single day, or maybe, a couple of times a week, you're not going to get that compliance through nasopharyngeal testing, and just a number of false positives, especially as people get hesitant or don't enjoy it, false negatives. Unlike, a saliva sample, it's quite hard to mess up, really. So I had been interested in pooling from the start. It is only something that, we've only been working on this for about 10, 11 weeks now and already done so much, but pooling has still been something we haven't done a lot of, because we actually, making testing accessible and meeting mass testing demands has actually become our #1 priority. So we've currently been working on a way of increasing the turnaround time for saliva sampling. RNA extraction free method, it can get a single test down to $1 or $2 instead of all of the other prices that everyone else is proposing. We want this to be able to just be accessible to anyone, schools, lower middle income countries, anyone who wants to do it, just to remove that barrier of price and to remove the barrier of supply chains as well. So that's one thing we're really focused on, is making sure that the method that we're developing can be used with a number of different reagents, different processes. And so that's what we've sort of been pushing through quite heavily at the moment, because we would really like to get this up and running and out there within the next couple of months, especially before school starting back. We're going to be able to get daycare centers to be able to do it. So I've only sort of been dabbling in pooling in a bit of my spare time, but even that is looking very promising. We've been looking, as been discussed, we've been looking at pool sizes of, 2 or 3 samples versus 5, 10, 20 samples, and we're getting quite encouraging results from that as well. So ideally, in the end, it would be, can we even, further scale this and combine both the pooling and our sort of mass testing approach and get down to, your pooled tests being only $1 or $2 a pop as well. So that's what I'm working on, and really happy to talk further, answer questions.
Your work is very, very important. You don't even realize. And for everybody, not having to deal with the swabs, saliva is so easy if it works. So it's a dream if it works. Tomer and Dror, will either of you share with us a little bit more about what you're working on and what else?
Hey, Steve, I can't let that one go. Anne has already proven that the saliva works and it's better. That's a solved question. And so like it's done, it works. And it's just, the only thing that's holding us back is the FDA won't let people do it.
So that's my next big thing is, and that's what we're doing with this. We're not looking for an FDA EUA, we're looking for an FDA method EUA, which means that anyone can. So at the moment, that's what all the CLIA labs are struggling with, is that every CLIA lab has to prove that they can do this and do it. We want this to be a method EUA, meaning that anyone can set it up. And they just need to do like a little bit of, verification, just make sure that their assay is actually optimized and getting the same results as they should be, but without this having to submit a whole new FDA EUA. So if anyone also has any, is aware of any FDA reviewers, we're actually trying to find some that we can maybe sit down with and have a chat, because just to really help us guide us through the process a little bit more.
But Anne, if I can just jump in, I mean, the best way forward here may be if Governor Newsom says every lab in California can do saliva tests following the protocol at Rutgers, because I say so, and because I'm writing the checks. And if Newsom does that, you got saliva testing in California.
Yeah.
Tomer, do you feel like saying something?
Yeah. Hi, everyone. So it's quite early here in the morning, but it was a very fascinating talk. We've been working as well for the last, I could say 11 weeks now on group testing. Our method is, I would say, more sophisticated and more implementable in a diagnostic lab, in the sense that it's a single step approach and it doesn't require, reaching out to samples again, which is I would say, a logistic issue that would, hamper many or prevent many diagnostic labs from actually considering group testing because of liability and because of the, worries of pulling out the wrong sample from the wrong freezer and you have to retest it again. And also because testing time, when you're doing these adaptive tests, doubles. So whatever the test time is, you need double the time. And that doesn't factor in the time required to get the result, pull out the sample, and everything else that happens in between, getting those two tests. We've been working with the Ministry of Health in Israel. We're in the midst of pilot with the Ministry of Health here to get what's, the sort of equivalent of the FDA approval for doing a test in Israel. We're working with, one of the biggest, healthcare providers in Israel, Clalit Research. And we're testing in the clinical virology lab at the Soroka University Medical Center here in Israel. We have a preprint online. We're trying to form a company that will actually make a method that other people could actually use, because we believe that to make this a viable solution, somebody would actually need to offer a way to do this in a streamlined fashion that would not require significant work from anyone on the supply chain. So it would require the lab manager, the technician, the diagnostic lab manager. It would require them to have a protocol that they could use in a way that would be streamlined like anything else they use, and allow them to actually use this. And I'm not thinking about the FDA process, whether it's required or not. That's a very interesting point brought up by Paul. I just think that making the process streamlined, simple, easy to use, and reliable, so that the lab on its own believes that they can trust this, would be very important, regardless of whether you have FDA approval or you just have government approval within the states and so on and so forth. So we're happy to discuss offline with anyone who's interested. Of course, saliva is super interesting. We've not tried to pull saliva yet. We're on the end of designing optimal ways of testing that would reduce the number of tests. And I should point out, currently tests are very, very expensive. No one's mentioned here that there is a bottleneck in the amount of money that a school can spend on doing testing. So even if the school gets, approval from the government, even if the school convinces the parents that they can, test, and even if the school uses saliva, if the test is still $50 or $100 a test, right? it's going to be very, very expensive and really not feasible to test on a regular interval. So group testing, and that has not been mentioned on the call. I think that should be like a really important driver of this entire initiative. It's a way to reduce cost, and reducing cost means you can afford more tests for the same amount of money you have. So if the government allocates a certain amount of money to do testing, and you can do 8 or 7 or 5 or 4 or whatever number of times tests with the same amount of money, that is going to make a significant difference. Also in reducing the interval between test times, which, as Darius has said, could be really important in preventing large outbreaks in schools. I should point out here in Israel now, there have been several outbreaks in schools in the last few days. The Ministry of Health has been testing extensively in schools and finding many, many asymptomatic children in schools. So probably the number of asymptomatic cases in children is likely to be much, much higher than in adults, which I think has been reported elsewhere. But now we're seeing this in large numbers. And it's all from super spreaders. Again, these people that are like very infectious and can spread disease. So I think the school actually is even a bigger problem that's been discussed here. I'll just end with that, saying that because those kids go back home, they're basically spreading the disease to everyone. So basically, keeping the schools open without testing is not just taking a risk that the school will become infected and maybe the parents will. It's actually a risk that the entire population will become spike again, because if the kids go to school and they all get infected, they come back home and infect all their siblings and parents, then we have an outbreak again. And I think I'll end here.
There's somebody named Stacy just made a comment. Can you share your comment, Stacy? Can you unmute yourself?
Sure. Hi, I'm Stacy Rosenson. I have a kindergartner, and just listening to this call, I would say that if we pool and do all these things talked about, like this just seems like a slam dunk, and that our kids can go back to school, and I am not struggling every day being a working parent and trying to get my kid on Zoom. So thank you all so much for your leadership and bringing this forward. And, to the degree I can, I will get this message out to everyone, because it is so important to get our kids back to school. And for $10 a week, I think we can make this happen at all levels. So thank you very much.
Yeah, I think thanks very much to you for taking time out of parenting a kindergartner to attend our talk, Stacy, as well. But I think that it can't be emphasized enough that we have to figure out how to get to a new normal in the presence of this pandemic. And everybody staying at home, and I mean, that was a valuable thing to do for a few months or a few weeks, but it's not sustainable. We can't continue to do this for a year or 2 years. So even though it's a huge challenge, it's a challenge that has to be met.
Tamara Miller, will you unmute? Tamara's a microbiologist and a school principal. So you get the science and you get the kids. Is there anything you could comment on?
No, I'm just listening to all of you, and I'm so hopeful about the saliva testing, and I agree with what Stacy said. This isn't sustainable. We need the kids back in school. We want to be back in school. We want to be with the kids, and we need to figure out how to do it safely. So I'm so appreciative of the science and of the research and everything that everyone's sharing. And I'm actually feeling more hopeful now after this conversation that we are on the right path.
It occurs to me that this is going to demand some sort of a lobbying group, some sort of a group of people who together, independent schools and public schools, we're all in this together. I see David Baca nodding his head, and that we need to lobby. I don't know, Paul, do you know, is going after the governor enough to get him to, can he negate the FDA's authority over CLIA labs? Or do we have to go directly at the federal level? If we were going to not spin our wheels, but to combine resources, and you should know these principals of some of the independent schools have some very influential parents on their boards.
Yep.
So you have a good group in front of you. Organize us.
Yeah, so I think there's 2 leverage points. One is anybody in the Congress you can get to and persuade them to spend money on, allocate the money for tests that goes to the states, and possibly even think about infrastructure investments that could improve like air quality within schools. I think anybody who can send that message, that could be influential. The representatives are kind of in these cocoons right now. They're not getting that much information. You get to them, they will listen. beyond that, what I'm told is the White House has signaled that it's willing to get the FDA to defer to the governors, so that if governors and their health departments say we're willing to do X, then the FDA will basically defer to them. So I think beyond the Congress to provide the funds, the real action now is to get to either Governor Newsom or Steyer, Tom Steyer, who's part of the recovery panel for Newsom, to get to them and persuade them that the first thing they should spend the money they get from the last bill on is they should commit that money for spending on tests when schools open this September. And then if everybody knows the money's there, then you can start to ramp up, like the university labs and so forth who could provide the testing for you.
Yeah, I think the good news there is that Steyer's group is already very interested in pooled testing, and they've reached out a couple of times on that point, which is fantastic. And I think the other point, I just want to reiterate something Paul said earlier, which is the use of university labs is very important potentially because it's a clear end around that avoids the FDA. The Department of Health and Human Services has already said that if you're dealing with a research lab, you don't have to get specific approval for pool testing. And that would be the reason to use the university labs. And moreover, maybe there's, I suppose you could debate this, but maybe they'd be more amenable to charging cost-based prices as opposed to harvesting profits.
Dror Barron wants to say a word. He's in North Carolina and has done some interesting algorithms. Dror?
Yeah, Steve, thanks a lot. First of all, I want to thank the other people that we've already heard from. And I want to kind of, make several points. One of them is that I think we can expand the conversation that this is not just about schools, not just about California, not just about the US, but for example, I'm sure we've all read that our meat processing plants are under stress. And if we don't test those people, it's going to be a complete mess. Many of us are ordering a lot of things online. And if the warehouse people are not being tested very frequently, it's going to be a complete mess. Our entire supply chain, which we're taking for granted, most of us, being comfortable in our homes right now, could collapse. So that's one point. Now, revisiting the point that Tomer made earlier, and I want to kind of sharpen this. On the one hand, the approach that Darius mentioned earlier for pooling, which dates back to the 40s, where first you group together 5 people or 10 people or whatever it'll be in a pool, and you see which pools are positive. And hopefully most pools are going to be negative, and occasionally you test each of the people in the pool individually. That's one approach. That's called adaptive. Adaptive because based on the information that you got in the first round, you adapt and you have a second round where you test only the ones that might still be positive adaptively. And as Tomer was saying, the non-adaptive approach means you design a sophisticated scheme of pools where every single individual appears in multiple pools, but on the other hand, you kind of design it in a clever way that you're not going to have a pair of people appear together in more than one pool and other such constraints. And now with only one round trip of tests, instead of waiting for an hour or half an hour, whatever the length will be, instead of multiplying that by 2, we don't need to do 2 rounds of tests, no longer adaptive. Now, there are a lot of considerations here. For example, maybe we really do care about which individual kids, or if it's a warehouse, which individual employee is shedding. Or maybe we have another approach. Maybe, we have like 20 kids in a class, and if any of the 20 are positive, we know that they've been hanging out over the last several days. It's likely that within 3-4 days, others, there are other considerations here, right? So do we actually need the power to decide which individual is sick? And now I'll just mention that what we've been doing since February is that in the group testing literature, to the best of my knowledge, much of the group testing literature covered the case where everybody has the same prevalence of being sick. Imagine that you have a coin toss and 2% of the time the coin lands on sick, 98% of the time you're healthy, and all the group testing approaches were developed for that. Now, in the last 6-7 years, my research group, we've done related algorithms for structured data. And the structure could be, for example, hey, these 5 people are family members, they all live together, and it's likely that if any of them have been infected, within 2 days, they're all gonna have it, or most of them. Similarly, what I was saying earlier about classes, if one kid has it, 5 others, or if you have people at a software company or a financial firm that are working, 10 in a room, stuff like that. This is easy to imagine. You can even use contact tracing information. And all this information can radically reduce the number of tests that you need. And whereas the method that Tomer was describing earlier, to test about 100 people, you need something like 13 measurements. We currently need 6, 7, but then there are new things here that people, again, haven't really considered in the past, such as the structure of the pools needs to adapt to the specific structure of who's in whose class and the social network. And so there's a lot of future work that I think that can reduce this further. So I think it would be very realistic within 2-3 months to be pooling together 20, 30 people and, significantly reduce the cost. And if Ann is correct, and we can get the actual chemistry test down to $2-3 and we divide that by 20, then it's so cheap and basically, anybody can do it every single day.
Thanks so much, Dror. David Baca, you said you don't want me to call on you, but you're like the most important thing here. You have 700,000 children. Has anybody reached out to you yet at any level of government, or are you just winging this?
Well, of course, we're in conversations with folks. As you may have seen in the LA Times, we're trying to put a stake in the ground for the need that we've really outlined here. And we just need that viable path forward in terms of funding, support, and what this is going to look like. But we're in that place of committing to both schools opening and finding out what that new normal can be. It's we're in that place of needing to be able to figure out what support is needed in order to really have a viable path that's going to work for us, who we serve, the funding we have, and the resources that we have within and around our district.
It's not funny. Paul Romer's father was the superintendent of the LAUSD, I think 2000 to 2006, right? Anyway.
Yes, of course. I mean, I should have started with a thank you for your service. Absolutely.
Anybody else? Please speak up, please. All right, Darius and Paul, why don't you guys wrap it up however you guys want?
Well, I'll just say I'm happy to talk to anybody else who wants to follow up. And David, out of your 700,000 students are my 2 daughters, so I'm particularly interested in providing you with whatever help and information you want. This is going to be a group effort between researchers and schools and workplaces, and we're looking forward to the challenge.
Looking forward to that. Thank you.
Well, let me just try and repeat that there's this very funny mix of both opportunity and crisis here. Even though very little is happening, I'm truly persuaded that it's possible for a few people to actually make things happen. This progress on getting the Congress to devote, like $100 billion to testing, this looks like this is going to work. And in the same way, I think in the governor's office, there's just lots of people who are kind of like almost like paralyzed because they don't have the confidence to just move. They're all waiting for somebody else to suggest something. So if a few of us just start moving and pushing, we might make things happen. So Steve, I don't know how to do this without flooding your inbox, but let's try and find some way for some of us to keep in touch and coordinate and see how we can push some levers and try and get some action, and perhaps have California be the state that, shows the whole nation the way forward.
You guys can email me. Don't worry about my inbox. It's already a disaster. All right. Thank you, everybody. Have a good night. Stay safe. Let's pray for everything to end tonight in Los Angeles. Good night.
Thank you.